Welcome to a new series of live clinical webinars. Every month, a different clinical modality will feature what is new in the exciting field of medical imaging. You can hear from some of the world's expert clinicians and have the opportunity to interact with them live. Who will speak to you today? In a few minutes, Professor Dr. Stefan Achenbach, our today's clinical expert, will start presenting low dose in cardiac CT imaging. Welcome, Mr. Achenbach.
Thank you. Thank you. It's a pleasure to be here.
My name is Christian Reichel. I work for Siemens Healthcare and I'm responsible for coordinating and organizing our global education measures. Within today's webinar, I will be supported by my colleague Susanne von Wittinghoff. She is in charge of the clinical education regarding computer tomography. Hello, Susanne.
Hello, everybody.
And now, I hand over to Stefan Achenbach. He is Professor of Cardiology within the Department of Cardiology at the University of Erlangen. He is an expert in coronary CTA and will talk to us about low dose in cardiac CT imaging. Please, Mr. Achenbach.
Thank you very much. Indeed, it is a pleasure to be here and to speak to all of you out there in the world and to be the first presenter in this exciting new education format. And the topic today is a very important one. It's about scanning cardiac CT datasets with low dose. You're probably all aware of the fact that CT imaging of the heart has made tremendous progress in the past years, and it is now possible to use it clinically in many instances to detect and to rule out coronary artery stenosis, for example in three-dimensional reconstructions as you can see over here, or in two-dimensional displays of the coronary arteries as you can see on the right-hand side. Clinically, this can be extremely useful and image quality has really become relatively robust, so this is a very helpful tool. One of the problems is that cardiac CT imaging, especially CT of the coronary arteries, has been targeted a little bit in the past years and months about the radiation exposure. Here are some headlines from the past saying that CT is an increasing source of radiation exposure, that radiation from CT scans may cause cancer, even some speculations about the number of cancers, 29,000 cancers related to CT scans in the United States during 2007, so there are concerns about increases in cancer risk because of increased radiation exposure due to imaging. So all of these concerns have taken a little toll on CT and has dampened a little bit the initial enthusiasm, and there are opponents and critics of CT who very much focus on the high radiation exposure. So today we'll talk a little bit about the radiation exposure and ways to lower the exposure without losing image quality in CT angiography. How high is the dose of coronary CT angiography? There was a very broad worldwide survey which was published last year, which looked at 50 different sites performing coronary CT angiography with different sorts of equipment, and a total of 2,000 patients. And here you can see the distribution of dose values at 50 sites throughout the world. And you can see that the average dose was 12 millisieverts. But the range from one site to the other site was very high. Some sites had doses as low as 4.6 millisieverts, while some other sites had mean doses of up to 30 millisieverts. So there is tremendous variability in the dose that is used for coronary CT angiography, and it was not paralleled by changes in image quality. So image quality can be very much the same in low-dose scans as well as in high-dose scans. So what I would like to do today is to talk about the potential strategies to lower radiation exposure of coronary CT angiography without losing image quality. And I'll take sort of a step-by-step approach to take you from a very easy basic beginning to more advanced stages and tell you what you can do to keep dose as low as possible. Let's start with a very basic, very conventional coronary CT angiography protocol. Traditionally, this has been done with spiral or helical acquisition using 120 kV tube voltage, and the traditional way of acquiring coronary CT angiography data is to perform a spiral acquisition with a very low pitch, so there's tremendous amounts of overlap in data acquisition, record the EKG simultaneously while the patient's X-ray data are recorded, and then retrospectively, using the patient's EKG, images are typically reconstructed in diastole to visualize the coronary arteries. If scanning is performed in this way, the dose can indeed be very high, because lots of parts of this long parts of the coronary cycle are irradiated without using the data for image reconstruction. So lots of radiation is wasted, so to speak, and the average dose of a scan like this will be somewhere between 20 and 30 millisieverts. However, since typically the images will be reconstructed in diastole, there's a very easy and straightforward way to reduce radiation exposure without having to change the protocol at all a lot, which is to use the so-called pulsing protocol, which is also called EKG-based tube current modulation, which means that the output of the X-ray tube is reduced in systole, because systole will typically not be used for image reconstruction, and then it is brought back to maximum output during the diastolic period, so that there is still flexibility to reconstruct a different time instance in diastole. And this EKG pulsing, which is simply an on-off button in your image acquisition protocol, so it can be activated very easily and you don't have to change anything else during the data acquisition, this EKG pulsing will reduce the dose to approximately somewhere between 10 and 15 millisieverts. So it brings approximately 40 to 50% reduction of dose when this is done. Depends a little bit on the heart rate, but the beauty is that you don't have to scan, that you don't have to change your scanning protocol at all. It's very easy for your technologists. They don't have to learn anything new. Simply switch on the pulsing button. The pulsing really reduces radiation tremendously. You do not risk image quality, and that's why it is general consensus that a standard protocol for coronary CT angiography should include at least the most basic form of EKG-based tube current modulation in every patient. That's very easy to transmit to your technologist. Simply switch on the EKG pulsing for every scan that you do. Another very easy way of reducing radiation exposure is to move away from the standard 120 kV acquisition. That's just historical convention to use 120 kV for image acquisition in coronary CT angiography. Here's a typical contrast-enhanced image, but it is just as well possible to use lower tube voltages for image acquisition. If you change the tube voltage from 120 kV to 100 kV, this will lead to tremendous reductions in dose. Dose will go down by 40% when tube voltage is reduced from 120 kV to 100 kV. On the other hand, image noise can be slightly higher, which is partly compensated by the fact that the contrast of iodinated contrast agent is also higher in the image. Here you can see a comparison of normal body weight patients scanned with 120 kV on the left-hand side and 100 kV on the right-hand side. And you can see that as far as image quality goes, these scans are absolutely equal. There's no negative image quality in the 100 kV setting, and that's what we consistently observe in our clinical scans, that 100 kV scans, as far as image noise goes, are a little bit higher, but not noticeably worse than 120 kV scans. Here you can see an example. This was a patient weighing 93 kilograms, 100 kV scan. You can see very nice image quality of the coronary arteries along the entire length of the right coronary artery and the LAD, and even the finest details are very nicely visible. Here, some small calcified plaques with the remaining normal coronary lumen using 100 kV, so you do not have to be afraid of significant reductions in image quality when 100 kV is used. I personally, a number of years back, before we started using 100 kV, was very reluctant to do it. But there's absolutely no reason not to use 100 kV, especially in patients who are not overweight. The downside of 100 kV is the somewhat higher image noise. And of course, the heavier your patients are, the more noise you will see. So there is a certain threshold above which 100 kV tube current should not be used. In the literature, you will find different suggestions for the threshold below which 100 kV tube current can be used and above which it should not be used. For example, 85 kilograms body weight has been suggested. Other authors have used body mass index to define the threshold. For example, body mass index less than 25 kilograms per square meter or less than 30 has also been suggested. One author suggested a combination. Body weight should be less than 85 and BMI less than 30. What we do at our institution, we try to keep it very simple. We use a body weight threshold, and our body weight threshold for less than 100 our body weight threshold for 100 kV tube current is 100 kilograms. So patients weighing less than 100 kilograms, unless they are very, very short, we do not calculate the BMI. Less than 100 kilograms, we scan with 100 kV, and this really significantly brings down our radiation exposure for coronary CT angiography. We currently use this in 68% of all our coronary CT angiography examinations. The majority of our patients have a body weight of less than 100 kilograms and can be investigated in this way. So my second summary will be that besides using EKG-based tube current modulation for every patient, you should really consider very strongly to use 100 kV tube voltage for patients who are not overweight. And again, the beauty is that you do not have to change your scan protocol at all. Everything else remains the same. The only difference is switching 100 kV to switching 120 kV to 100 kV tube voltage. For your technologists, nothing else will change besides the button for the voltage has to go from 120 to 100 kV. The typical dose that can be achieved in this way, if you combine EKG pulsing and 100 kV tube voltage, is about 7 millisieverts. And that's already a very, very reasonable dose for coronary CT angiography. EKG pulsing, as I explained it initially, will keep up the radiation exposure to the full tube output during a long period in diastole. But of course, it can also be done more aggressively. The modern scanners allow you to interactively define how long the period of full tube current should be, and it can be shortened, for example, to 60 to 80%, or kept very, very short, just around 70%. You lose your flexibility to reconstruct different images at different time points a little bit, but it can be used to reduce radiation exposure even more, especially in patients with very low and stable heart rates, if the window of full tube current is narrowed, and the narrower you make it, the lower your exposure will be. A very narrow pulsing window can be used for patients who have low and stable heart rates, because in these patients, up to about 60 beats per minute, you know that you will reliably get diagnostic images around 70% of the cardiac cycle. For higher heart rates, more than 60, 70, 80 beats per minute, you will have to try and see whether diastole or systole gives better images. So in higher heart rate patients, you cannot keep your window very, very narrow. You should open it up from 40 to 80% of the cardiac cycle. But in low heart rates, you can make the window of EKG pulsing very narrow, just around 70% of the cardiac cycle, and will remain very good image quality. This is already a little bit more complicated than what I have explained before. This requires some thinking, and it has to be adapted from patient to patient, but this can also be used to further reduce the radiation exposure. And if you combine 100 kV tube voltage with EKG pulsing and a very narrow window of full radiation, those can be brought down to about 5 millisieverts, which is even more reasonable than the 7 millisieverts with standard EKG pulsing. Sometimes there is worries that the using EKG pulsing will compromise your ability to look at left ventricular function because tube output in systole is lower. Unfortunately, this movie of LV function analysis does not transmit very well over the internet, but I can assure you that you can very nicely delineate the contours of the left ventricle even in systole, and it is not impaired by using EKG pulsing. So EKG pulsing fully keeps your ability to look at left ventricular function by CT angiography. So my third summary would be that if you use EKG pulsing, if your technologists are good enough, you can think about adapting the window width of full tube output. And if the heart rate is low, less than 60 beats per minute, and stable, you can use a very narrow window of EKG pulsing or very narrow of full tube current to further reduce your radiation exposure. Siemens offers a further option. You can switch on the min dose button, which brings down the radiation exposure outside the window of full tube current even more. In systole, radiation output goes down to 4% of the full level, and this will further decrease your radiation exposure. In this case, however, you lose the ability to reconstruct functional data sets. If you are more experienced, you can actually change your imaging protocol and go away from spiral acquisition and instead use what is called prospectively EKG-triggered axial acquisition, which basically means the step and shoot acquisition. You acquire images at one level, then the table is advanced to the next level, and the next set of images is acquired. Siemens uses the term sequential or sequence scan for this prospectively EKG-triggered axial acquisition. It is often also called step and shoot acquisition. With the step and shoot acquisition, you only give radiation at the very time instant when you want to acquire images. So this is a very low dose protocol, but you do not have flexibility to reconstruct different time instants after the data has been acquired. Depending on the scanner that you have, it will take a certain number of cardiac cycles to cover the complete volume of the heart. With a 64-slice CT, it's about 6 to 8 steps, 6 to 8 cardiac cycles to acquire a full data set. With the 128-slice scanner, it's about 3 to 4 steps, 3 heart cycles or 4 heart cycles to acquire a full data set of the heart. Theoretically, systems with even wider detectors will allow you to cover the heart in even less than 3 steps, 2 steps for the 256-slice CT, and theoretically only one single acquisition for 320-slice CT. All the manufacturers use sequential scanning, step and shoot scanning, but they use different names for it. Snapshot, pulse, step and shoot, Shure cardioprospective, GE, Philips and Toshiba terms. The Siemens term is sequential scanning. In reality, most of the very wide detectors use more than 1 or 2 steps, more than 1 or 2 cardiac cycles for image acquisition, because for higher heart rates, they do take repeated acquisitions, between 2 and 4 repeated acquisitions to allow for multi-segment reconstruction, because the temporal resolution of these scanners is lower than the temporal resolution of dual source CT. That's why they compensate by acquiring several cardiac cycles and using multi-segment reconstruction. Sequential scanning, step and shoot scanning, affords very high image quality when the heart rate is stable. Here you can see a bypass patient. You can nicely delineate the entire course of a bypass graft and also the distal, the peripheral run-off vessels. Very good image quality for this sort of scanning. How high is the dose for the step and shoot acquisition? That's the good question, but it's not easy to answer. There are many publications out there who have looked at step and shoot acquisition, but the dose is very, very widely because it depends on a lot of factors. Did they use 100 kV or 120 kV? What tube current was used? What was the scan range? Was multi-segment acquisition used for higher heart rates? So if you look at the publications that have described step and shoot scanning, you will find a very wide range of radiation exposures. In these publications using 64-slice CT, you can see that the dose varies somewhere between 2.8 and about 4 or 5 millisieverts. We have 2 publications looking specifically at dual source CT, step and shoot acquisition, and you can see the dose reported was 1.4 millisieverts. And then for the 320-slice scanners, because as I said, often multi-segment acquisition is used, dose depends on the heart rate a lot, and was somewhere between 2.4 and 14 millisieverts in this publication. Here's an example of a patient studied by dual source CT. You can see it's a young woman, and in young women we want to be especially cautious with radiation dose. 32-year-old patient with atypical chest pain, prospective trigger, step and shoot acquisition or sequential mode, 100 kV tube voltage, and the dose was 1.7 millisieverts. And you can nicely see a high-grade stenosis in the left circumflex coronary artery, while the right coronary artery and the left anterior descending coronary artery are normal and show no stenosis. Here's a three-dimensional display also showing this high-grade left circumflex stenosis. And this is the corresponding invasive angiogram. So in my next summary, I would suggest that at least for those who are somewhat more experienced, switching from a spiral acquisition to a step and shoot prospectively triggered sequence acquisition is a very worthwhile idea when the heart rate is low, less than 60 beats per minute, and stable, doesn't change. Then using the prospective trigger can be routine and will never decrease your image quality for low and stable heart rates. We use it quite a lot in these patients. Finally, there's a new scan mode for the newest dual source CT, the so-called flash mode. The flash mode is sort of a hybrid between a spiral acquisition and a prospectively triggered scan, because it's a prospectively triggered spiral acquisition with a very high pitch, which means that the patient table moves very rapidly during acquisition. It moves so fast that the entire volume of the heart can be acquired in about 260 milliseconds. Images are reconstructed with a temporal resolution of 75 milliseconds per image. And the first image in the dataset will be reconstructed at the very initial time of this 260 millisecond window, while subsequent images are reconstructed a little bit later, so that the first image and the last image of the dataset are not acquired at exactly the same time instant, but there are slight changes in the time point of image reconstruction for each slice in the dataset. This is not visible though in the dataset. This is a typical flash high-pitch spiral acquisition scan of CT angiography, and you can see very, very nice image quality in this case. And it's usually better to look at two-dimensional images when you want to judge the image quality, and also very nice image quality throughout the entire right coronary artery in this case. The flash scan affords a very, very low dose because there's absolutely no excessive or superfluous radiation exposure. Here's an example of a patient scanned with 100 kV tube voltage, flash acquisition, and the dose is 0.81 millisieverts. Very nice image quality for the coronary arteries. Here's another example. 75 kilogram patient, 0.89 millisieverts for visualization of the coronary arteries, in this case with the flash mode. We looked at a series of 50 patients. We used a threshold of 100 kilograms and a threshold of a heart rate of 60 beats per minute, 100 kV tube voltage, 320 MAS, which is our standard protocol for flash scanning, and in 50 patients achieved an average dose of 0.87 millisieverts, and every single case the dose was less than 1 millisievert. So this is a scan mode which really allows to use very, very low doses in somewhat selected patients, low heart rate and not excessively high body weight. Especially in the young ones, especially in the young patients, we want to keep dose low. Here's an example of a 27-year-old patient who came to the emergency room. Body weight was 99 kilograms, so that's not a very slim patient. Had chest pain and a family history of coronary artery disease. CT was used to rule out coronary artery stenosis, as you can see in this reconstruction, and the dose was only 0.9 millisieverts, definitely less than an invasive coronary angiogram would have been. Are there problems with the flash mode? Yes, as I indicated before, this is not a scan mode for every patient. A stable heart rate is necessary. If heart rate changes just before the acquisition, the scan mode has problems and it can result in a little bit of motion artifact. The reason for this is that the table has to move very fast and it has to accelerate over about 3 seconds. So image acquisition is triggered by the EKG approximately 3 beats before the actual image acquisition occurs. And if heart rate changes during this time, the image acquisition might end up too early or too late in the cardiac cycle, and this can lead to somewhat decreased image quality because of motion artifacts. So that's why we use this scan mode only in patients who have a very stable heart rate which does not change, so that we can avoid this problem. Here are examples of coronary artery stenosis visualized in the flash mode. Here's a high-grade, very short, eccentric stenosis of the left anterior descending coronary artery. This is the corresponding invasive angiogram. Here's a three-dimensional reconstruction of the same case, and again the invasive angiogram for correlation. So the flash scan is a wonderful option to keep doses extremely low. In fact, it can be consistently less than 1 millisieverts, but patients really have to have a stable heart rate, and they should be less than 100 kilograms so that 100 kV tube voltage can be used. Here once again is an example of the image quality that can be obtained using the flash mode. So basically there's a whole variety of scan modes that are available for coronary CT angiography with modern scanners. And depending on the scan mode that is used, you can basically dial the radiation exposure for the patient. A standard protocol which really doesn't require lots of input by the technologists will typically be about 13 millisieverts if EKG pulsing is used with 100 kV. But simply switching to 100 kV can bring down dose to about 7.5 millisieverts. And then with more and more expert scan mode settings, you can be as low as 0.9 millisieverts for the flash mode, or, which can really be very frequently used, the prospectively triggered acquisition, 120 kV for the heavier patients, about 3 millisieverts, 100 kV for the slim patients, about 2 millisieverts. And these are very, very low doses that can be achieved in everyday practice. In the future, we will probably be able to bring those down even more. Iterative reconstruction is one of the options that we will be using in the future. I'm pretty sure about that. Iterative reconstruction makes more effective use of the X-ray data. Image noise is lower, as you can see in this comparison between standard and iterative reconstruction. And because image noise is lower, you can use lower tube currents, and this will bring down dose even further. You can also think about using 80 kV tube voltage. 100 kV is already better than 120 kV as far as image quality is concerned, but noise goes up a little. The same holds true for 80 kV. Noise goes up even more. Dose goes down even lower. And this can be used in very, very slim patients. Here's an example of a patient weighing 57 kilograms, prospectively triggered acquisition, 80 kV, dose of 0.6 millisieverts. Especially if we have listeners in Asia, where patients tend to be of very low body weight, this can be used excessively, very, very frequently. I have colleagues in Singapore, for example, who use 80 kV almost as their standard, and they can have very, very low doses for their patients. So in summary, what is our experience? What is our strategy for coronary CT angiography to keep radiation exposure low? We use spiral acquisition for complex patients, for example, patients who have complex disease, implanted stents, and other factors, and for patients who have a high heart rate that cannot be controlled. We always use EKG pulsing with spiral acquisition, which leads to reasonable dose values even for spiral acquisitions. The prospective trigger is sort of our workhorse. It's our everyday scan mode. It's extremely robust unless the heart rate is too high, and we typically end up with about 1.5 millisieverts for our patients weighing less than 100 kilograms. And then in patients where we want to have the lowest possible dose, that's where we use the flash acquisition. Requires a low and stable heart rate, but will consistently give us a dose of less than 1 millisievert up to 100 kilograms. So there are lots of options, and this is the strategy that we follow in Erlangen. I would like to finish, though, by making a very important point. We have many options to lower the dose in coronary CT angiography, but we should not compromise image quality for dose. Image quality comes first. Good image quality is the most important aspect, because bad image quality can lead to unnecessary downstream testing, which is probably worse than giving some radiation to the patient to get good images in the first place. Low dose acquisitions are most important for younger individuals, and that's where you should really focus on getting the dose low. But always remember to not sacrifice, not compromise image quality. With that, Thank you very much for your attention, and I look forward to receiving some questions.
Thank you, Professor Achenbach. We already have received a couple of questions, which I will show you in the presentation and also read to you out. So the first question was, do you use 100 kV protocols with the flash mode?
Yes, indeed, that's a good question, and we do use 100 kV. We sort of independently always use 100 kV when we have the body weight of less than 100 kilograms. No matter we use a spiral acquisition for complex and irregular heart rates, a prospective acquisition for our sort of workhorse scan mode, or a flash mode, whenever the body weight is less than 100 kilograms, then we go to 100 kV. This can be combined very nicely. And for the flash mode, our specific settings are 100 kV tube voltage and 320 MAS tube current.
Okay, thank you. Let's get back to the next question. Sorry. Does contrast depend upon kV or kVp alone, or are there any other factors like MAS, signal-to-noise ratio, etc.?
Well, the contrast in the image will depend on the kV setting. Signal-to-noise ratio will be influenced by the body weight, and MAS will also influence image noise and therefore the signal-to-noise ratio. The contrast itself, the contrast between iodinated tissue and not contrast-enhanced tissue, the contrast between bone and fat, it depends on kV and not on MAS or other factors. But image noise is influenced by MAS, image noise is influenced by body weight, and this will lead to decreased signal-to-noise ratio.
Next question is, how do you calculate the dose in millisieverts?
The scanner will give you a dose length product, DLP. And the dose length product can be converted to effective dose in millisieverts by using a factor. And most commonly at the moment, we use a conversion factor of 0.014. So that a dose length product of 100, DLP of 100, will correspond to 1.4 millisieverts. There is some debate whether 0.014 is the correct factor to use. It's likely that it will change in the future. It might be differentiated between men and women in the future, but currently this is the most frequently used conversion factor.
Thank you. You showed in your table the different vendors, the different dose. The question was there, why is there no study on a 256 light scanner from Philips?
I don't know why. I haven't found a study on the 256 Philips scanner. If I find one, I'll happily use it in my presentation. But the studies that I found that looked at the step and shoot acquisition or the prospectively triggered acquisition were performed with the GE scanner, the Siemens scanner, or the 320. I have not found anything on 256, which doesn't mean that it's not out there. It's simply I haven't found it.
Next question is, when is the best image available? I guess it's referring to best image quality.
Yes. Also, in most cases, we will find best image quality at around 70% of the cardiac cycle. When you reconstruct your image, around 70% of the cardiac cycle typically gives you the best image quality when the heart rate is low. Low meaning below 65 beats per minute, approximately, definitely below 60 beats per minute. You can rely on the fact that late diastole, about 70% of the cardiac cycle, will give you the best image quality. In higher heart rates, this will change from patient to patient. Patients with higher heart rates, in some cases you will have best image quality in diastole, 70% of the cardiac cycle, but in other cases it might be in systole, typically around 35 or 40% of the cardiac cycle. So in high heart rates you need flexibility so that you can reconstruct different time instants to really pick the best image. In low heart rates, it will typically be around 70% of the cardiac cycle.
What MAS is prescribed for 100 kV prospective triggered acquisitions, like reference MAS? I think you already said it. Yep.
Typically 320 MAS is what we use.
What about MRI?
Well, MRI has no radiation exposure, and it's a perfectly good question. For any clinical question that can be answered by MRI, this will probably be our method of choice. If you think about studies performed exclusively for left ventricular function, if you think about late enhancement, if you think about perfusion, MRI is a good tool. If you want to visualize the coronary arteries, magnetic resonance imaging does not have the same accuracy as CT angiography, and that's why for coronary angiography, magnetic resonance is currently not a clinical tool.
Next question. I think we already answered that. Does contrast depend upon kV? You already said.
Yeah, the contrast that you see in the image will depend on the kV setting that you use. And maybe the person who asked the question was asking about contrast agent or contrast agent injection rates. We do not alter them with the kV setting. We typically use an injection rate of 5 milliliters per second, no matter whether we use 100 or 120 kV.
Do you use flat detector CT like DynaCT during or in a coronary disease? If yes, how high is the risk there?
We don't use it. We don't use DynaCT, which is a fluoroscopic acquisition. It cannot really be used to visualize the coronary arteries very nicely. So that's not something that we can report on at the moment.
Then we have some more questions that came up during our chat, so I'll read them directly out of the chat. So how much is the increase in the doses of contrast from 100 to 120 kV?
Well, we do not, as I said, we don't change our contrast injection protocol. Our contrast injection protocol is 5 milliliters per second for 10 seconds, so usually 50 milliliters of injection. No question no change whether it's 100 or 120 kV.
Then another one, why do you use 100 kV depending on the patient's body weight and not BMI?
Well, that's simply because it's easier for us to determine, and we have it's easier to simply ask the question how much do you weigh, and we don't have to do the math to calculate the BMI. And we actually did a scientific study, and it showed no difference to predict image noise, whether we use the BMI or the patient's body weight didn't make a difference. So the only reason why we do it this way is to keep it simple for our technologists. They don't have to do any calculations, simply ask for the body weight.
Thank you. The difference in doses in regards to radiation between CT angiogram and a normal angiogram. You have any values there?
Mm-hmm. That's a wonderful question. The problem is that we do not have very reliable reports about the doses in invasive angiography. Typically, it is assumed that invasive coronary angiography will be somewhere between 3 and 5 millisieverts. 3 to 5 millisieverts for invasive coronary angiography. Of course, if you have a very experienced investigator who tries very hard to keep the dose down, it will be lower, and a beginner will have a higher dose. And we also have to keep in mind that the dose in invasive angiography depends very, very significantly on the patient's body weight, because the fluoroscopic systems increase their output for heavier patients to keep image quality constant. So heavy patients will have substantially higher doses.
Okay, second last question. Do you still use beta blocker with the flash scanner?
In patients where we want to keep the dose low, for example, young patients, it is very advantageous to have a low body weight. So for radiation, it is very advantageous to have a low heart rate, because then we can use these very, very low dose protocols. So we give beta blockers to the patients to bring down the heart rate, to be able to use very, very low dose protocols. In patients where we cannot control the heart rate, we use other scan modes, as I said, the spiral mode, for example, with EKG pulsing. But we do use beta blockers in those patients where we want to keep the dose low.
I think the next question is in the same direction, what to do when the heart rate is not stable.
When the heart rate is not stable, the only limitations that we have basically is we are not so happy to use the flash mode. But we can still use prospective scanning if it's not too bad. We can use the adaptive sequence, which compensates for changing heart rates a little bit. But we typically, if the heart rate is really variable, we typically switch to a spiral acquisition.
Do you use nitrates to improve visualization of coronary arteries?
Yes, absolutely. That's an excellent question. It does not relate to dose, but I would like to say that it's very important to use nitrates. Nitrates dilate the coronary arteries, they increase the flow in the coronary arteries, and it is very, very widespread consensus that you should use nitrates for every coronary CT angiography that you perform, except in those patients who have contraindications like aortic valve stenosis. And nitrates are very useful. We give a sublingual spray of nitrates just before we move the patient inside the scanner, and it really improves image quality a lot. All the experienced sites use nitrates.
Okay, last question that just came in. What is the main difference between spiral and step and shoot?
Well, the main difference is that in spiral acquisition, the table is moved continuously, and the X-ray tube gives radiation continuously, so that after the scan, you have flexibility to reconstruct your images at any desired time point in the cardiac cycle. If you use EKG pulsing, the images in systole will be higher noise, and images in diastole will be lowest possible noise. But in spiral acquisition, you acquire data continuously while the patient moves through the scanner, and you can reconstruct after the acquisition at any desired time point. With the step and shoot acquisition, you acquire images at a given time point, then this X-ray tube is switched off, the table is moved to the next position, and you acquire images at the next time point. There is a certain possibility, it's called padding, to give you some flexibility in reconstruction, but it's not as wide as with the spiral mode. So with the step and shoot mode, you use some flexibility as to your possibility to reconstruct retrospectively after the scan is finished at different time points in the cardiac cycle.
Can we use the flash option in scanning a children's heart?
Yes, the flash is very good for children's hearts, because the shorter the scan range, the easier it is to use the flash mode, because the window of image acquisition becomes shorter and shorter as you make your scan shorter. So it's very often used for pediatric imaging. It will not give you the possibility to look at function. That should be said. Function cannot be analyzed with the flash mode. So if you want to use function, you have to use the spiral mode, and then in children typically you use 80 kV tube voltage, of course, because they are of their low body weight. But flash can be used for children's hearts.
Thank you, Professor Achenbach. Is there no more open questions in the chat? At least one more thing from my side to mention is the presentation was recorded, so the whole webinar was recorded and can be downloaded in a couple of days on our internet page. With that, I will hand it back to Christian. Thank you, Professor Achenbach.
You're welcome. It was a pleasure to be here.
Thank you, Professor Achenbach, also from my side. Thank you, Susanne. Before we will finish this today's session, I would like to give you a short overview about our upcoming webinars. On January 20th, we will hear about emergencies in neuroimaging with MR. The topic on February 17th will be interventional imaging, hybrid surgery. On March 17th, we will present multimodality reading in oncology with Syngovia. And in our session on April 21st, you learn more about molecular imaging, IQ SPECT, intelligent cardiac SPECT. Please note that the agenda maybe is subject to change. For updated information, please visit our website www.siemens.com/clinical-webinars. About 2 weeks prior to each webinar, the registration form will be available. So, thank you for your attention. We hope you enjoyed this session, and we would be glad if you would join the next webinar again. We wish you a Merry Christmas and a healthy and prosperous New Year. Goodbye.